Welcome everybody. I'm hoping that you've all managed to navigate the registration process. Welcome to this second webinar relating to the Serious Illness Conversation Guide training. I'm going to ask Jane to start us off with a karakia. Jane?
Te whai. By many, by thousands, the work will be accomplished. Unity is strength.
Thank you so much, Jane. Mohammed, could you please move to the next slide? Mohammed? Oh, awesome. Thank you so much. So I want to just acknowledge our technical support, Mohammed, who was awesome in the first webinar, and I'm hoping that he's going to make this as smooth as the last one went. So welcome. Thank you all for taking time out of your busy days to join us for this webinar and to explore the serious illness conversation in a little bit more detail. My name is Leigh Manson. I'm the program lead for the Serious Illness Conversation Guide program and Advanced Care Planning at the Health Quality Safety Commission. With me today on the panel, I have the National Serious Illness Conversation Guide trainers. So I'm going to introduce you to them. You'll see them pop up as they answer and address different parts of the webinar today. So Jane Goodwin, Dr. Prue McCallum, Dr. Lynn Twigley, Carla, Arkless, and Dr. Oleg Kiriaev. Alrighty. Mohammed, do you want to pop to the next slide, please? So we're hoping that this is interactive and you send us your questions during the course of the webinar, and I'll be monitoring those and feeding them to our panel. On the screen at the moment, you'll see where you need to click in order to type us a question. So you click on the little icon at the bottom of your screen and send us a question. And hoping that this runs smoothly and that you're forgiving of our second webinar experience. Alrighty. So Mohammed, next slide, please. So just a quick outline of the webinar today. Jane's going to take us through the Serious Illness Conversation Guide overview, and then we're going to look at different components of preparing and having the conversation, and then we're going to end with some discussion around talking with whānau. So I'm going to hand over to Jane Goodwin.
Kia ora, thank you guys. And we're on the move to the next slide if that's all right. Awesome. All right, so the Serious Illness Conversation Guide was originally created by a team of clinicians working closely with consumers, and they were based at Ariadne Labs in the United States. Their work was led by Twigley, who some of you may have heard of before for some of his work with Being Mortal, a book that he wrote that I think was on the bestsellers list in the States for a long, long time. The idea of the guide was really to support healthcare professionals navigate conversations with seriously ill patients. And what they were consistently hearing in their workplaces, and what we've heard similarly in New Zealand, is that often our clinicians feel underprepared to have these conversations, and it's tough sometimes knowing how to navigate it and to stay on track and to do it in a way that feels safe and okay for the patients and the whānau we're working with. So what the Serious Illness Conversation Guide is it's a list of patient-centered questions which are designed to assist the clinician in gaining a more thorough understanding of the patient's life in order to inform care decisions. So it walks the patient through their understanding of their illness, elicits information about their preferences for information. It asks them about their personal goals, their fears and worries, and it asks them about things like their abilities they find most important in their daily life and the trade-off that they're willing to go through for the possibility of more time. And we know that as clinicians, often when we're faced like stressful situations, and having a serious illness conversation with a patient in whānau is definitely categorised as a stressful situation for most of us, it really does help to have language to turn to in order to make sure that we're covering off the key questions and to allow us to address the important issues in a patient-centered and efficient way. It also sometimes gives us a bit more headspace to actually attend to what's going on for the patient and respond to the emotion that they may be experiencing by the conversation. So, Mohammed, if you could flick to the next slide for me, please, that would be great. Fabulous. So when it comes to the Serious Illness Guide, we've been working on this project in New Zealand for around the last 18 months. And it started with a whole lot of work, co-design work across the country with consumers to adapt some of the language to make it feel more relevant to our Aotearoa community. And what we've seen since we've been using this guide is that it has been helping clinicians successfully navigate conversations and grow in confidence when they have these conversations. And I guess the sort of key points that come out of this are the consistency. If you stick to the guide, if you say the words, if you acknowledge the emotion, if you agree a plan and write it somewhere for people to refer to, it can be a really useful part of the process. Next slide, please. So why do we have 3 serious illness conversation guides? Well, the first one we've just, we're going to talk, or the version we're going to talk probably most about today is the Aotearoa version, which is the one we developed originally 18 months ago. In addition, in the last month or so, we've also created 2 further versions of the guide that are now in our suite of 3. The first is a COVID-specific serious illness conversation guide. And that was what the focus of last week's webinar was predominantly about. So if you want a little bit more detail about that, check out the Talking COVID website and find our webinar from last week, and it will talk you through specifically the aspects that are captured in the COVID version. Essentially, it gives us a bit more detail to help navigate the conversations. Our prognostic statements have been tweaked to relate more specifically to COVID-19 expectations of what that person's recovery may be. And the explore section has been shortened to sort of recognise that clinicians and patients may not be in the position to have as much time and energy to navigate that part of the discussion. And the final section, or the close of the conversation, when we think about our recommendations, we've given some suggestions that they may link to the goals of care categories that are being used on the National Goals of Care form. The other addition to the suite of serious illness conversations guides is the COVID-19 whānau SICG. And that is aimed at supporting conversations, often by phone, with the whānau of people that have a positive diagnosis. And we're using that to help gather information from whānau if the person is unable to be giving some of that information to us themselves. So it's a very similar to the COVID framework, but it just helps us to pitch it to a whānau rather than to the individual having the conversation. Okay, next slide, please, please, Mohammed. So let's just really briefly look at the Serious Illness Conversation Guide Aotearoa in a little bit more detail. As we navigate the webinar today, the crew are going to take you through the different aspects more specifically, but just as a general overview, it really helps us, this guide, to be navigating conversations with seriously ill patients to elicit their understanding of their condition, their goals and priorities, and to support us to make recommendations that align with the aspects that are most important to that person and their whānau that are supporting them. When we presented last week, I guess we were still thinking we were in the thick of the COVID crisis, and we weren't quite sure what our numbers and trajectory of cases may be in New Zealand. And, you know, for reasons of that, we were focusing predominantly on the COVID version. But I guess as things have transpired over the last sort of week to 10 days, and we're seeing our numbers generally decreasing across the country quite significantly, we're thinking that this is the version that you'll probably be using most often. It helps us navigate conversations with patients that do have a condition, something that's sort of to base the conversation on, seriously ill. And we do know that it can be successfully used to navigate conversations even when people have a degree of heightened anxiety around COVID. And if you watch the training video we've pulled together, there's that example of Lynn having a conversation with David, and she uses this framework to have the conversation, but also has space within it to be acknowledging his anxieties and concerns about what might happen if he did develop a COVID diagnosis. Cool. So now I'm going to hand back to Leigh, and she's going to start talking us through or opening up the questions for the webinar. Thanks.
Thank you so much, Jane. Maybe before I do that, I'm wondering if Carla might want to talk about this. So should clinicians be using this for all patients? Carla, what are your thoughts?
So yeah, it's designed to be used for people with serious illness, for those that are currently seriously ill, or those who have a known risk of becoming seriously ill. Of course, the communication principles can be used in other situations, but the language, the questions, they're specifically designed for the context of serious illness. So the Aotearoa Guide is designed to be used ideally ahead of a crisis or health decline. And it provides the opportunity to bring the patient up to speed, as Jane said, about their current situation and what might lie ahead for them, and then explore their goals and priorities. So yeah, I mean, the principles can be used in other situations, but the language is specifically focused on the serious illness context.
Thank you so much, Carla. So maybe a follow-on question for you. So you would have a serious illness conversation guide conversation instead of an ACP conversation?
Well, you know, it is kind of an ACP conversation. It's just a focused one. It's a specific context within the whole realm of advanced care planning. So I guess the serious illness conversation might lead to a more detailed advanced care planning conversation, or the completion of an advanced care plan. And that might well become one of the recommendations at the end of the serious illness conversation about, you know, going on to complete an advanced care planning document.
Really, thank you so much, Carla. Mohammed, I'm wondering if you could move us to the next slide. And then just to remind our participants that this is the beginning of Q&A, so please feel free to send us your questions by clicking on that little button with the two speech windows that says Q&A and sending us your questions. Alrighty, so Mohammed, if you could move to the next slide. So I'm going to be asking Jane. Jane, do you want to talk to us about preparing patients and whānau for difficult conversations, please?
Absolutely. Thanks, Leigh. So I guess when it comes to thinking about these conversations and discussions, it is always best if we give people a bit of a heads up that we're wanting to talk about this. And that's for multiple reasons. One, it gives them a chance to be prepared, and this is not like blindsiding them coming out of the blue, but it also gives them the opportunity to do some preparation, to think about what they might want to be asking or considering, and also to make sure that the people that are important to them or are available to support them might be able to be present. I guess that's particularly important that we have a bit of a heads up around that in our current climate, where a lot of these conversations and discussions we're having with patients and whānau might be remotely, might be via technology like we're doing today. So it's really useful to be able to sort of have a bit of a priority and a heads up to start with, so we can link everybody in that needs to be there. When we think about these conversations in a context of discussion, it's also important to think about how we are supporting the cultural needs of the person we're talking to. And one of the model that we sort of use with our program is the hui model, which was came out of work by the Canterbury division of the University of Otago. And it uses sort of it uses a Te Ao Māori framework to help us navigate the conversation. And it uses mihi as the initial greeting, and this may involve karakia if that feels appropriate for the person. The whakawhanaungatanga is that opportunity to make a connection with someone in some way, to sort of develop that rapport at the start of the discussion. Kaupapa is the work of the conversation, the mahi of the conversation, and I guess when we look at the guide, that is when we're getting into the discussions about the person's understanding and what's important for them during the explore section. And then porapora aki is our opportunity to conclude the encounter, and that would be what we consider sort of the closed section of our guide. So using that framework sits really well alongside the work that we do with the Serious Illness Conversation Guide. When we're thinking about preparation, this can happen in several ways. It might be that we send a letter out to prepare them. It might be that we give them the heads up that this is a conversation we want to have, that in a time we see them previously. Yeah, and it just really helps us to sort of set the scene and mean that it's not a complete surprise to that person.
Thanks so much, Jane. Here's a question, which I think I might be able to answer. Are there letter templates or patient resources? So Annexure A of the Clinical Reference Guide, which is one of the resources on Talking COVID, does have a letter template to be sending to patients prior to having the serious illness conversation with them. And at the Commission, we are starting to look at some information resources to provide to patients and families before a shared goals of care conversation. So we'll be sharing that on our website when it's available. Alrighty. Mohammed, I wonder if you could move to the next slide for us, please. Okay, so Jane, I'm going to ask you to keep talking to this, please. So what are we doing when we're setting up and why, please?
I guess essentially the setup of the conversation is establishing the relationship with the person in the whānau that we might be talking to. And it involves things like the connection with that person, the introduction of the idea of what the Serious Illness Conversation Guide is, and potentially the benefits that it might be for that person, so they understand why we're wanting to have this conversation with them. It's really important, if at all possible, that you think about how you might make a connection with someone, and that is some of that work you might do before you sit down with them to have this conversation, to have a look at their notes and their background to see if there's something that you can connect with. I guess in the example we saw on the training with Lynn and Oleg's character, there was that opportunity to have that connection between sort of the IT component of the work that David was doing in that space. So it's really just having some way of catching up with that person and seeing where they come from or what's important to them. And there's also the opportunity then for us to be, as we're sort of setting up, talking to them about, it could also be really important to have someone with you. We hope that some of that preparatory work has happened and that they have encouraged people to be with you, but in the context of the Aotearoa environment, if they don't have someone with them, we still have felt, and our consumers, when we pulled this work together, felt it was really important that we make sure we offer again if there need to be other people there to support them in that space.
Thanks, Jane. So, Christian, could you provide us with an example of how you might create a connection to whenua in the setup to the conversation?
Yeah, so if you're thinking about whakawhanaungatanga, that opportunity to connect with that person in some way, one of the examples that the Hui model often uses about it can be a connection to place. So asking that person maybe where they are at the moment, and that's probably particularly useful in the environment we are if we're doing some of these conversations virtually, but also where they're from or where they come from or where they hail from or where feels important to them. And that's an opportunity to hear where their whenua, their land, their connection is. And we can often share our connection as well in terms of I know that place, or I'm from, or I was originally from, and that just helps us to navigate some of that.
Thank you, Jane. Mohammed, I wondered if you could move to the next slide for us, please. Alrighty, so Oleg, this is one for you to have share a little bit about establishing the patient's understanding of the current situation and the importance of that. So hand over to you.
Yeah, thanks, Leigh. I guess from a communication perspective, gathering information is just so fundamental to what we do when we're practicing good communication skills, that in terms of actually thinking and why is it so important, I needed to put a little bit of thought towards that. But I guess it's just, essentially for me, it's important to clarify and prioritize people's information needs right at the very outset, pretty much in any conversation you have, but especially when it comes to serious illness conversations, you really don't want to get it wrong, because you might only have this one chance. And time again, you know, as clinicians, you know, we always find it so tempting when we have important, vital information that we feel we have to impart, that, you know, often, you know, we simply just blurt it out. And I guess, you know, thinking about that, we can actually appreciate the many risks as well as downsides with that approach. And I'm sure everyone, you know, has pretty much had experience with that and encountered that in their own practice. So, you know, in terms of checking in with them first, if nothing else, then that just simply allows you to take a breather and to pace yourself and to gather your thoughts and to go at their speed. I think also it gives them an opportunity to talk first. And I think that helps to, balance the power dynamics even just a little bit. It gives them voice before you use your voice. So, so what they say not only gives you a sense of what sort of information they might require, but also gives you a sense of how you can best provide it. And I think that's a good reminder for us to use their terms and their phrases and steer ourselves away from using jargon or terms that, in actual fact, they might not understand. And I think it also helps us, it helps to give us a bit of a heads up in terms of how they might be feeling at the moment, in the moment, and that's important because we know how vital it is to acknowledge and address whatever feelings that they might have churning around inside first before we impart any information. So I think there's a lot of really good reasons as to why we gather before we give, but finally simply to say it's essentially just a much more efficient use of time because you end up spending most of your time and effort in the areas that are most required.
Awesome, thank you so much, Oleg. I'm wondering, Mohammed, could you move to the next slide? Thank you. So where Oleg left off is sort of really good segue into this section for Prue to talk about if you could help us understand when to use which prognosis, that would be awesome. Thank you so much, Prue.
So as Oleg said, it's so nice to hear from the patient first so you have an idea of how they're feeling, but the language they use. And it's also an opportunity to address any sort of myths or misunderstandings. So then you go into this phase of it by saying what your understanding is. So you don't need to do a big information dump because they've already told you what their understanding is. So your understanding just needs to fill in the gaps. One of the very powerful part of this serious illness conversation guide is the prognosis sharing and what the options are on this sheet. So if you just go back a slide, yeah. So there are 3 options, and when you use this tool, you choose one of these options. Traditionally, we used to think of giving prognosis in terms of giving a time prognosis, and felt that we needed to know how long someone had, and that was the only way we could share a prognosis. But this tool gives us 2 other options. For example, if we look at the bottom one, we can say, I hope this isn't the case, but I'm concerned that this may be as well as you feel and things are likely to get worse. So this is just an indication that their function might change, and it's a warning shot that things might get worse. Other times you might want to use the uncertain prognosis because it's difficult to predict what they can happen. You hope they continue to live well for a long time, but it's possible they could become unwell quickly, and we want to prepare for that possibility. And at other times, it is appropriate to say that you wish this was not the case, but you're concerned that time might be as short as days or whatever you need to say. So you go into using the serious illness conversation, pre-deciding which of these statements you're going to use and which is most appropriate for the setting. Another advantage is that if a clinician's using this tool and they're not someone who knows what the definitive time prognosis is, they might feel more comfortable using a function statement or an uncertain statement because it's can be used by, I'm thinking for example, like an OT who might use the function statement and wouldn't have to address the actual time component. Following this, and most importantly, is to allow some space, to allow silence. The statement that you've just shared could well be a shock. There are very likely to be emotions associated with it. And we need to acknowledge or validate or even just explore those emotions. You might like to, there might be some things that you might like to say. These are just some examples. For example, this must be very hard to hear. I can see that this is very upsetting to talk about. Or I wish this wasn't the case. Those sort of statements to, so that they know that you've acknowledged what it's like for them.
Thank you so much, Prue. I have a question. If I could keep you on the line. So here's the question: can I skip giving prognosis, particularly if my patient is well?
Well, the whole point of this conversation is that it takes place in a serious illness. So this is a goals of care conversation for a seriously ill patient. It's very important that we do give a prognostic statement, because the whole conversation is pinned on the fact that there is a decision to be made because things are changing. So if we miss the prognostic statement, then the conversation doesn't really have, it's not grounded. So it's very important that we do share, and we do share one of these prognostic statements.
Awesome, thank you, Prue. So I've got another question. Carla, I'm going to give you this one. So what do I do if the person refuses to accept the prognosis?
Yeah, that's tricky, hey. But I guess our role isn't to force an understanding. It's to provide information and opportunity to understand more about their health. The language that is specifically chosen in this guide is chosen to offer hope whilst being honest about their current and likely future health. And I think it really provides an excellent opportunity for people to start to hear the reality. At the end of the day, it's up to them whether they allow that reality to sink in for them. But I think the language in the guide gives a really excellent opportunity for that to happen. And, you know, the other important thing is about responding to the emotion, the empathy. That's really important here, because it will help them to take on board what might be really hard to hear. It kind of, you know, builds that trust. Can I trust what this person is saying? If we're acknowledging the emotion and giving empathy, demonstrating empathy, it helps them to know that they can trust what we're saying as well. If they're still not on board with the reality, you know, in this prognosis stage, several of the questions during the explore section help to reiterate or reinforce the sense that things are likely to change. So again, it's up to them. We're not ramming it down their throat, but there's opportunity repeatedly for that reality to sink in.
Great, thank you, Carla. I have another question. Lynn, I'm wondering if you could be ready to take this one. I'm worried the patient might get really upset, difficult enough when in the same room, but how do I deal with that on the phone or on video? Lynn?
Yeah, so this is really tough, and in any context, whether we're face-to-face or whether we're on a video conference or on the phone, we worry about how what we're saying impacts on the person that we're talking to, and it's especially challenging if we're missing one of those big channels of communication that we rely on, which is non-verbal cues. I guess there's a few points in this. One of the things I think that can be challenging when we're talking to people on the phone is that we might tend to rush on a little bit, and silence can feel quite uncomfortable. It is really important to remember that the information that we've just given, the prognosis that we've given, might take a little moment to sink in for that person. It might take them a little second to have those thoughts and feelings that will come up for them. So even though it's difficult to sort of sit on your hands with that moment, that is quite important. The next thing that sometimes might happen when you're on the phone is that silence just continues and you don't know how things are going for that person. So once you've given it a chance for the information to be received, I think it's really important to use our words to try and uncover what's going on with the person on the other end of the phone. So it might be that we have to actually draw that out with our words and say, you know, I know I've given you something, you know, really big to think about. I'm just wondering how that's landed with you. Sometimes it depends what you know about that person, about how they like to talk about things. So with someone who is comfortable with expressing their thoughts, you might say, hey, I'm just wondering what, you know, what's going through your mind at the moment. Or you might say, you know, I wonder about how you're feeling after what we've talked about. So we're actually being much more explicit with our words to draw out the response. The other thing that we've heard from our colleagues in the US who are using the Serious Illness Conversation Guide in the COVID context, and from some of their conversations with families and whānau in this situation, is that they do recommend that if you do have the opportunity to do a video call of some kind, that does have an advantage, because although it's not the same as being in the room, you do get that chance to pick up a little bit more on the non-verbal cues. There is a little bit more opportunity for that sense of connection, and also it seems to be a little bit easier for people who are highly anxious. So if there's a chance to do a video call over a telephone call, that would certainly be our suggestion.
Awesome, thank you so much, Lynn. I'm going to come straight back to you once Mohammed moves the slide. So Mohammed, could you move on to exploring priorities, please? Awesome, thank you. So Lynn, could you provide us an overview of the exploring section, please?
Yeah, sure. So this section is our opportunity to really give the person their voice, and when we're in that situation where it's not a crisis and we've got that opportunity to really hear about where this person is at, all 6 of these different areas are important. So they all contribute something different. We're asking about, as you can see, priorities, worries, strengths, critical abilities, trade-offs that people are willing to go through, and also family awareness. And I guess one of the things that I sort of always reflect on is that different things are going to be top of mind for different people, and so it builds this picture, it builds our insight into what's going on for that person that we're talking to. And the other thing that's interesting as people talk about this and have the opportunity to talk about all of these aspects is it also increases their insight into what they are thinking and feeling. So sometimes just hearing it out loud actually helps someone think, oh, actually, I feel like this about this situation. They might not really have reflected on that. So there's a reflective sort of element to all of these questions as well. And there's also quite a purposeful order to the questions. So when the guide was designed, the Explore section is designed to help people to get through thinking about these quite tricky aspects. So we go from topics that often will elicit sort of more positive, hope-based thoughts, and that's often what you'll find out with priorities. And then we might work on something that's a little bit tougher, like what are you worried about? So there's an ebb and flow of the sort of difficulty of the questions, and that's quite important that we keep them in that order as well. The other thing that I think is very important is that this is patient tested language, and it's also that it's been tested in New Zealand. So the way that these questions have been designed is so that there's the best chance that someone will understand what you're trying to get at, and that it will be gentle and safe and possible for them to give answers about them. One of the things that I've often heard when I'm doing training is that people are concerned that if we go through these questions and we follow this, this is a conversation with an agenda, that we're not really listening to patient cues or following patient cues, and there's a concern that we're not being patient-centered. And I think that's a really important question, an important point that people raise. And one thing that I think is critical if people bring something else in, which will often happen, they'll bring in another concern, is that we do acknowledge that concern and then negotiate with the person about whether it's okay to come back to that a little bit later. And we have to acknowledge that that is a trade-off. If we had unlimited time, we might follow every cue that comes up with the person. There's some downsides to that, obviously, in terms of time, but also sometimes the conversation might become too full and too overwhelming for the person. So there is a trade-off here where we're looking for it to be manageable and efficient and safe on both sides, really. So I think always it's important to remember that if something really critical and overwhelming comes up for a person and you feel that, you need to stop to deal with that issue straight away, that's okay. You can pause this conversation and come back to it later if something comes up that feels that it's the most important thing that day and you need to pause and attend to that. We don't want people to feel like they're a robot that just has to keep on ploughing through. We have to remain humane. Yeah, those are my thoughts.
Awesome. Thank you so much, Lynn. So here's a question for the panel. Relating to doing a video call or a telephone call. The question is, would you record or store the video call as health information? I was wondering who was keen to have a go at that question. Awesome, Jane.
So I guess there would probably depend on what your local DHB's policies were around such things, and also whether you had somewhere to be able to store that safely. And I guess obviously you'd need to negotiate with that person if it was okay for that to be recorded. So I know that lots of DHBs are looking at the moment. I know our local DHB here in Waitaha, Canterbury, are looking at how we navigate some of those things in our current environment. So I'd say check with your local teams, see what the deal is, check with the patient or the whānau if that feels okay. Because it's not just capturing it, it's also where we keep it afterwards to make sure it's safe and secure.
Thanks so much, Jane. So while I've got you on the line, here's another question, Jane, you might want to take. I don't like the trade-off question, feels uncomfortable. I worry that it might be interpreted as a reference to euthanasia.
Yeah, that is something we have heard from a number of clinicians, and it's really interesting for me in my time using the guide to support conversations. That has never been how I've experienced it being interpreted by patients. I definitely have had euthanasia and assisted suicide come up in my normal ACP conversations, but not when I've used the trade-off question as part of the guide. And I guess for me, the bottom line is if someone did interpret it that way and did want to give us that information, actually that's quite valuable to know and to hear where they're up to with their thinking. It doesn't mean we need to act on it or use it. It's just being able to say, I hear that's important for you. That's really useful for me to know where that sits with you. And I guess as we would in any of these conversations, if someone tells us some of that information, we are still bound by what the legislation is in this country. So, even if someone told us that that's what they wanted, at the moment it's not legal. If it does become legal, we'll still need to fit within the parameters of what is required within the system and the structure about how that might work and look and what that was going to be for that person.
Awesome.
I guess, sorry, Leigh, we're going to...
No, I was gonna ask you whether there was another example of a type of trade-off question or the type of trade-off questions that you do get other than the one that's been asked about.
Yeah, lots of people talk about their ability to be at home. If they, couldn't be at home, that wouldn't feel so okay for them. I've had a number of examples during the COVID situation where people have talked about their trade-off in terms of, if I got sick now, I'd want to stay at home. I would want to be with my whānau. I wouldn't want to be especially if they've got other underlying health conditions, going to hospital doesn't feel as okay for me as it would normally because I wouldn't have those support people with me. So it really depends on, it's very individual for that person. It's about what's okay or not okay for them. And it can be really helpful for us to kind of elicit or get a sense of what is their bottom line. And that can really help us if we're needing to make some clinical decisions down the track for that person, having a sense of what's not okay or is okay or what that quality of life kind of looks like for them really helps us.
Thank you, Jane. Mohammed, I'm wondering if we could go on to the next slide, and then I'm going to ask Lynn to talk about what's important to consider during the recommendation or the close. Thanks, Lynn.
Sure. So I guess when we get to this part of the conversation, we're taking that opportunity to draw together and summarise all the things that we've heard the person say to us. And that's powerful in itself, and just having had someone truly, you know, be listened to about where they're at. And then we're using that information to make a clinical recommendation that sort of aligns with what we've heard, and also what we know from our expertise and experience in terms of what's clinically available and appropriate. And I think one of the things that's really important to highlight about recommendations is that they don't need to be a treatment. It doesn't need to be, you know, something about a future or a current treatment. It may be that the thing that seems most relevant to that person at the time is another conversation, or it might be that you're going to recommend to them that perhaps they consider bringing another family member in to discuss where things are at and what their wishes are. So very important to kind of have a broad list of options in your mind about what the recommendation might be. And the other thing that I think I always like to try to remember when I'm making a recommendation, which I'm, you know, trying to tailor to that person, is to make it tentative, because I'm still working on, you know, my sense of how things are from what they've told me, but I need to check that with them. So when I make a recommendation, it's not, you know, we must do, it's I'm thinking that, and reiterating to them that the reason I'm thinking about that is so that we make sure that their care is focused on what's important to them. The other thing about this part of the conversation is it is where we can pick up and make a plan of maybe some of those other things that the person brought into the conversation earlier on that we've parked. And it might be that we make a plan to have another conversation or provide support about some of those other aspects. So this is where we can address some of the other agenda items that the patients brought in during the conversation, and make a plan to deal with those later on as well. Yeah.
Thanks so much, Lynn. Here's a question. Carla, maybe if you could take this one. So we say we're going to do everything, but we know we're not. Do you want to grab that one? Thanks, Carla.
This is something that many people worry about, you know, promising things that we can't provide. But in actual fact, we're not saying we'll do everything in the universe that's scientifically possible. What we're saying is that we will do everything we can to ensure that they get the best care possible. And the specifics of what that best care might look like will depend on the situation. It'll depend on what's clinically appropriate at the time, what's possible in terms of services and resources. And yeah, so that's what we're talking about, rather than promising the universe.
Mm-hmm. Thank you, Carla. So before we go on to talking about talking with whānau, there are two questions that I'm keen to put to the panel. The first one is, can we start using it now? And the other one is, what is the uptake from DHBs and GPs in practice? Yep. So maybe Carla, if you wanted to take the first one, which was, can we start using it now?
Yeah, so short answer, yes, please do. I've just an example, I guess, of that I know of where it's being used recently. So I've been involved in setting up a community rapid response team, and a couple of the nurses that are involved in that, when they visit patients, they've started to use the guide. It's a new tool for them. They weren't using it previously, but what they're finding is that patients and family feel heard. They've got a good understanding of what's happening with their health, something that they didn't have prior, even though they'd had numerous contacts with the health service. And so they're able to make informed decisions about the kind of care and treatment approach that is going to work best for them. And it's kind of feels a very shared decision making because of the conversation. So yes, I'd really encourage you to start using it. It makes a difference.
Awesome. Thank you, Carla. So who wanted to take the second question, which was around Jane? Yeah, you happy to take that one? So what is the uptake for DHBs and GPs in practice?
Yeah, so it's I guess we've been up and running for 18 months with ACP, or sorry, Serious Illness Conversation Guide in New Zealand, and we've done a small amount of training, but I guess putting out the resource that we did a couple of weeks ago is to really help support the uptake and the environment we're in. We know that we're hearing more and more about different options and opportunities and where it's being used. One example locally for us here in Canterbury is the COVID ward we've opened, which anyone with suspected COVID or COVID symptoms is coming through. And our consultant that's leading that is using the Serious Illness Conversation Guide with all the patients. She's encouraging her registrars and house surgeons to do the same. And we've just in Waitaha, Canterbury, finalised our shared goals of care documentation, which we're going to be using now across a number of the wards and environments. And that incorporates reference to the Serious Illness Conversation Guide to navigate that part of the uncovering conversation with the patients. So it's starting to become integrated into a lot of the work we're doing locally. And my understanding is there's a number of other DHBs that are also working to be integrating the framework of communication used by Serious Illness Conversation Guide in a number of the other projects and work as well.
Awesome. Thank you so much, Jane. Mohammed, it might be a good chance now for us to move on to the whānau resource slide, please. Maybe just before we go there, just please, Mohammed, could you go back one quickly? Sorry. I wanted to, there, I think you've gone a little bit too far, Mohammed. You've gone all the way to the beginning. I wanted to remind everybody that it's really important to document this stuff down. So whatever you've learned in the conversation, to make sure that we're capturing it somewhere. If you're not using a shared goals of care format, that you're capturing it somewhere in your clinical notes or elsewhere and sharing it so that this information is not lost and we can be using it when we're thinking about what treatment and care to offer. All right, so I'm hoping Mohammed will get to the whānau slide in a moment, which is, Mohammed, it's slide number 17, the one after that one. And then I'm going to hand over to Oleg to talk to us generally about when we talk to whānau, instead of the person, as well as when we have whānau in the room with the person. So I'm going to hand over to Oleg if you want to talk to that. Thank you so much.
Yeah, thanks, Leigh. So I guess it's worthwhile and important for me just to mention that no one lives in isolation. We're all surrounded by the people we love. And it's the connection with these people we have in our lives that gives it meaning. In this sense, for me at least, really comes to me time and time again when I ask a person in front of me, you know, what they value, what gives their lives meaning. And typically, they always come back to me as their family providing them the greatest meaning and something that they have the greatest priority for. So at least in my mind, the question isn't why we should talk with and involve family, but in actual fact, why we don't talk with family and involve them in discussions. And so I think, you know, by default, we always should involve them to the best of their capacity. Obviously, the main reason why we don't talk to family is because it might well be that person's wish. But often, you know, this isn't an outright refusal. It's just simply for them that it's not the right time, or that they might have some fears or other concerns. And if that's the case, then absolutely address these first before, you know, and prepare them and support them to reach out to family. A problem might arise often in the acute setting when a person might be confused or otherwise has a diminished capacity to engage in these conversations, or to guide us with regard to their family preferences. But I think even in this situation, it's important for us as clinicians to support them to the best of their capacity and include all family who feel that they have a stake in their loved ones' well-being. And absolutely, I agree, it does add complexity, it does add dynamic, it does, you know, it's often very messy, families, but families by their nature are messy. It's important, at least for me as a clinician, to appreciate that this is the family's messiness. This is not my messiness. I'm there to support them, but they need to nut it out amongst themselves in terms of what the right way forward is. So I think, you know, that's absolutely vital. And I always go by, you know, the adage that at the end of the day, after everything's said and done, everyone, clinicians, family, other people, need to be able to walk away knowing that they've done their best. And I think it's our role to ensure that family can gain that sense. I'd like to refer people through to the additional training resources available on the Commission website that gives an example of having a conversation with a whānau member. And so, you know, the resources are there. I'd encourage everyone to have a bit of a look. Thanks.
Thanks so much, Oleg. I'm conscious that we are starting to run out of time. So maybe, Prue, this is particularly sort of a question that does pop up and that I'd love you to have a go at. So we know there are other comms tools and guides out there. Why should clinicians consider this one?
So that's a great question. So there are some fabulous communication resources out there. I think the first thing to recognise is that some of the communication skills are for different parts of clinical communication. So there are tools to break bad news. There are some for triage, some for gaining information about early goals of care. This is particularly dealing with, it's a goals of care discussion for someone with a serious illness conversation. So that's the first thing to say. It's got a specific place. There are other tools that deal with gathering information about goals of care for patients too. And they're based on the same principles, which is finding out what's important to the patient, giving the clinician words to say, because these are stressful conversations and it's useful sometimes to just be given the right words to say, that especially if it's patient-tested language. This is based on evidence. It's good if a tool listens to the patient before you do the talking, and in fact listen more than you talk, and really important to acknowledge emotion. So I think the key is to choose a tool that works for you. So get a tool that feels right for you and begin to use it till it feels natural. So the most important thing is to have these discussions with a tool that you feel familiar with and you're happy with the language. I would like to just say one further thing about the language. When you first use a tool, for example, the Serious Illness Conversation Guide, the words can feel a little bit clunky, for want of a better term, and words you wouldn't normally use. So first of all, I want to remind you that this is patient-tested language, so it's language that has actually been okayed. We know it's safe to use. And the other thing is that just something quite interesting happened in the Bay of Plenty. So in the Bay of Plenty, we have a pre-anaesthetic clinic for complex patients to determine whether they should have the anaesthetics, whether they should go ahead for surgery. And they've been using the Serious Illness Conversation Guide. And with time, they've become familiar with the guide and have tweaked some of the words and have become, very familiar really. And the observation and the feedback we've had is that they've gone back to using the words on the guide. And the reason they've done that is because they work, because they're succinct. And that's just an interesting observation. over time. So my comment really to that would be, find a tool that works and use it. Become familiar with it and use it.
Thanks so much, Prue. So I'm going to maybe just whittle around the panel and give you each an opportunity to give some final closing remarks. Carla, can we start with you, please?
Just really relating to family, because I think there was a question about, you know, whether we had tips to ensure, you know, people are appropriately sharing information, especially when we're having isolated conversations. So I guess it becomes part of the conversation towards the end. You know, how much do your family know is one of the questions, and so it's an opportunity to figure out who's in that person's life and who needs to know the information, and then ask permission or make a plan around that. Do you want to have the conversation with them? Should I have the conversation with them? Shall we do this together? So it's really just yeah, bringing it all together towards the end and including family in that planning side of things. So
awesome, thank you so much, Carla. So Oleg, I'm going to ask you for your final comments next.
Oh, simply, like I said last week, I think, you know, clinicians just simply need to go out there and do it. Take the guide with you, use it, say you're going to use it. Patients don't mind. You know, even give the guide to the patient after you've used it, so that they have a copy of what was said, and you know, and you know, they can be very useful as well. Yeah.
Thanks so much, Oleg. Lynn, if you could go next.
I guess for me, it's acknowledging that these are difficult times, that, you know, we're all struggling with rapidly changing work conditions, and everybody's got that little underlying bubble of anxiety. So we realise that it can be a big ask to maybe use a tool that's not so familiar, or to have conversations that feel like they might be difficult. And along with that, there's also that sense that this is an enormous gift that you can give to your patients with serious illness. It is something that we really can do. I think a lot of people at the moment are thinking, I'm powerless in the face of all of this. I don't know what to do. I don't know how to help. We know this helps. We know this allows patients to express where they're at and to make sure that they get care that aligns with where they're at. So even though it is difficult, I really encourage you to give it a go, and also to look after yourself while you're doing that. Make sure that you have a way to debrief, to look after yourself, to take care afterwards. Thanks.
Thanks, Lynn. Mohammed, could you move to the last slide, please, with the post-it on it? I see we've had the whānau guide in the background. That'd be awesome. Thank you. So who's next? So Prue, did you want to give us your final remarks, please?
Say, use the words, they work, and just don't forget to acknowledge the emotion, because these are emotional conversations.
Yep. Thanks so much, Prue. All right, Jane, so final wrap up.
I just want to thank everybody so much for taking the time to join us today. It's been wonderful having you on the list, for the questions that have come through, for the questions that we've pulled together from the things that we hear often when we're teaching and out and about. We hope it's been useful for you. I guess my final thought today is just think about who we can be having these conversations with, who's available. I know a number of districts are starting to think about their most vulnerable in the community and getting some clarification from them. This might be a tool to help support those conversations in a structured way. So definitely worth giving a go and getting some practice around. And you're very welcome to contact us at the Commission if you've got any further questions. Leigh and Mohammed will dish it out to the crew to be able to answer and come back to you with some responses. So please do feel free to keep in touch, and we'd like to thank you very much. So ka kite everybody. Leigh's going to close with a karakia for us, and yeah, have a great rest of your afternoon.
Thank you, Jane. All right. Irangi e papa e te whānau atua, whakatauhia tō koutou manaakitanga, ki roto I tēnei mahi o mātou, Sky Father and Earth Mother and the family of gods infuse your blessing upon this work. So thank you so much to the panel, and thank you everybody that joined us today. Bye.